This is the Dallas Morning News.
Well, Pete McCanna, who's the CEO of Baylor, joined us. And I thought was interesting, he has very early on described his industry as a mess, the healthcare system. But it was fascinating to listen to a very well-spoken, committed, dedicated individual to change that system and improve it based on both personal experience, but 4 decades of experience. And what they're doing at Baylor and talking about the healthcare system, I thought was fascinating.
Well, his personal element was really what stuck out to me. The idea that his father had a really significant illness and ultimately saw the healthcare system inside out. And that, I think, has shaped how he is leading a 57,000 person organization, over 7,000 doctors, is really just fascinating because he's getting an inside look at what the patient relationship looks like, as he calls it at Baylor, the customer relationship. And we dive deep into all of those things in this.
And this is something that touches every one of us. Every one of us are in the healthcare system. We deal with all the issues, and it was a fun conversation to talk about how he views it, leading that large organization, but also when he talked about some of the macro issues of the problems of our American healthcare system and what we need to do to try to address those.
Well, we get into innovation, we get into the administration, we get into medicine as a whole and pricing. We really span the gamut on this conversation.
It was wide. It was a big ocean.
Tune in. Welcome to Intersections, where we take a multi-generational look at the critical issues facing America. Tom, you want to introduce our guest?
Sure. Pete McCanna. Pete is the CEO of the Baylor Health Care System, largest in Texas, one of the largest in the nation. 7,200 physicians, 52 hospitals, nearly $16 billion operating budget. I think something that he is very attuned to, over $1 billion worth of community support. Pete, it's great having with you.
Great. I'm really happy to be here.
So you've been in healthcare for 4 decades now. Why healthcare? What was the attraction back then?
Yeah, it's a good question. I think the short story was I was in graduate school, and I was at the LBJ school at University of Texas. And I think my motivation to go there is I wanted to get into something that made a difference in society and my talents to do that. And I thought getting into public policy was a pathway to that at the time. And I studied under a guy by the name of Wilbur Cohen, who was the first secretary of HEW under Lyndon Johnson. And he had come to Texas late in his career and taught at the LBJ school. And he took me aside. He said, we had to pick an industry. It was kind of crazy, like, I'm going to pick, oil and gas, or I'm going to pick this. And he said, you should pick healthcare. And I said, why? He goes, because it is so messed up and it needs young leadership. And at a very young age, you're going to get into some pretty meaty issues. So I think that sort of technically got me there. I think in my heart, I wanted to be involved in something where I could really make a big difference, and that was consequential to people, and that made us.
Now, somewhat from a family background too.
Yeah,
you had parents that had some health challenges. I know your father had Parkinson's.
Yeah,
how did that impact the decision?
Well, my father had Parkinson's late in life, and I can share that because that has a lot of implications for how I view healthcare today and at Baylor Scott and White. I think what affected me and my formation is my mother had a chronic disease, which at the time was untreatable. She was bipolar, manic depressive, and big family, and she was in and out of the hospital a lot. And I witnessed how poorly our healthcare system for her condition basically did not exist for her. She was pretty much untreated or poorly treated during that period of time, and she was a nurse. So that got me, that influence also got me into that.
In your background educationally, you mentioned the University of Texas.
Yeah.
You came undergraduate, though, Michigan. So Michigan to UT.
Yeah.
So I guess we asked, with football season coming up, where are the loyalties?
Go
SEC
Blue.
Or
wow.
Go Blue. Oh, that was pretty clear.
That was quick.
Oh.
Even though you brought out University of Texas on the front end of it.
There's no question.
Are they going to have a good year?
we've got a freshman quarterback. So, but I feel bad for this guy because it's like here you are, your last football game was, high school, and now you're 100,000 people. I think the fans will, one game, we'll give him one game, but then we need to start winning. So he's got a lot of pressure. I think I have pressure. That guy's got a lot of pressure.
That's a different.
But we'll see.
That's fun.
So let's talk Baylor. Give us the origin story. How'd you get to Baylor Health Care System? Where'd you start? All of that conversation.
Yeah, how did I get to Baylor, or the long story?
You started out in finance first of all.
Oh, yeah.
In healthcare within finance.
Yeah.
In New Mexico, and then moved into more the operations at Northwestern and into Baylor. So talk about that transition of kind of entering from a financial standpoint, but then all of a sudden having, as you've got now, as I mentioned, responsibility, which I can't even imagine how you manage 7,200 physicians.
Yeah.
We'll get into that later.
You don't, man. I think, if I reflect on my career moves and decisions have really been based upon impact. Going back to my original, it's like, where can I have the biggest impact? Let me seek out. And I got encouragement early on. I think my dad's influence. He was a finance type person. And I had a propensity for it. I had one of my mentors say, get into finance, and at a very young age, you're going to have an impact, and went up that track. And as I went through finance, I had to self-teach myself finance. My undergraduate degree is in English, and my graduate degree is in public policy. I take online accounting classes. I used to take out the Wall Street Journal back where it was a more technical publication and read all the transactions and try and look up, what does that mean? What does this mean? And just try to immerse myself in it. And what I liked about it is you could, there was a bottom line to it. So there's a lot of activity, but then at the end of the day, you had to measure it and you had to say, did you get there? And my transition, in your question, my transition to operations was one of, wow, there's this operations opportunity. I can become the chief operating officer. More impact, opportunity to learn. And it was a fabulous growth for me because I was able to take some of the skills and approaches to finance and broadly finance, not accounting, but corporate finance and all that, and apply it to operations in an industry where one might argue isn't really tight around operations, and be able to ask questions like, well, that's interesting activity. How are you measuring that? What is the overall outcome that we're shooting for? What are our core metrics on this particular operations? What really matters to us? How should we plan for the future?
And a pretty complex organization in Northwestern.
Yeah.
With not only all the healthcare system, but the educational component and research attached to it.
Right. And sort of what is the operating, I had a financial model that I refined over time that really I felt very strong about, is how I could take an institution, organization at different stages in it and really improve its finances and make choices. I mean, finance is about making choices, and apply that to operations and create an operating model. And within that operating model, what is our core discipline? What are our principles? What are our outcomes? And what choices are we going to make with it? And how does it repeat itself over and over and over? And to be able to fuse the two together and create strategy and convert strategy and the financial plan and fuse that together was exciting to me. And I felt like I had a new career. I felt like I was 22 years old again, and learning and asking and really being a sponge. And it helped me, I think, as a leader, because the people around me knew a lot more about what was going on than I did. So if I ended up in operations, one of my first things was the operating room had a problem. Well, I had to gown up. I had to go in there. I mean, that's intimidating for a, 45-year-old person whose whole career has been in finance. I was familiar with it, but I'd never been really behind the wall, and start talking to people and tell me more about this and tell me more about it. And it was just fascinating to me.
So as you got into operations, your first reaction? You said earlier you got into it because the healthcare system was a mess.
Yeah.
When you went in as the head of operations at Northwestern, same reaction? It's a mess?
Yes. And not a mess at the individual level, not, in fact, amazing at the nurse to patient, the physician to patient level. Amazing. But everything around it, the incentives, the supports, and even, at times the system made no sense. And as you zoom out from healthcare and actually use analogs from other service industries or manufacturing, there's very little recognition at that time. So this doesn't make sense. We're not supporting these providers in a way. It's balkanized in many ways. It's overly complicated, and so that was, I mean, the positive side of it, I was like a kid in a candy store.
Mm-hmm.
Like, hey, what about this? Doesn't make any sense. Why is this occurring here and why is this occurring here? Why don't we understand our demand? We're showing up every day, and we do this every day. What is the data telling us about what the demand is coming in? What are we doing about access? I mean, when I was at Northwestern, I don't think this has changed much at Northwestern, probably at some academic centers, but the clinical leaders, the department chairs and their administrators used to talk with pride of how long their wait lists were, because that's how see how prominent I am.
People want to see me. Yeah.
People want to see me, and if we run into a rough patch, all I got to do is just reduce that wait list, and we're just fine. I mean, what business?
And that's kind of the perspective you've brought to Baylor, in the sense of, instead of looking at assets, I've got lots of hospitals, et cetera, you've tried to shift their viewpoint to look at it from the customer standpoint. So that wait list all of a sudden isn't on the good side; it ends up being on the bad side.
Yeah. And initially, I came at it from I would say a very rigorous rationale and analysis from a business perspective. But early in my tenure as CEO, in particular, as president and CEO, that's when my dad's disease came in. And, as I mentioned, I have 5 brothers, a big family, and my dad gets Parkinson's, right? And they kind of turned to me. I'm the CEO, so I guess I'm the expert, but to help manage his care. He was in upstate New York at the time. And I saw through his eyes how broken the healthcare system is. And I saw the issues of, it's episodic. It's not personal in any fashion. It is hyper attentive to hospitals and clinics, but once you step outside of that realm, there are no supports in the home, medication management, access to information that allows a family member to help navigate. And my dad was a very analytical person. And when I would come to visit him, he'd make a list of things that needed to change. Like, this doesn't work. This doesn't work. This doesn't work. And why is it this way? I mean, he was just like, what kind of train are you running here? I mean, and initially that list was for him, but
now, was he in your system?
No, he was in a different system. But frankly, it could have been any healthcare system in the United States. And he would say, he cared for my mom. My mom had a chronic condition, and she had diabetes, and she had her mental illness. And he said, why does mom have to go into the doctor every so many times to manage her diabetes? Why can't they do it at home? Why isn't it easier? Why do I have to go in if the doctor, here's Rochester, New York in the wintertime, and why do I have to go, and why can't it be seen at home? So issues of virtual care. Why can't you schedule the appointment for me? Why are my medications, they're making me feel, the mixture of them, bad? I don't know what's going on. And he'd make this list, but increasingly he'd say, what are you going to do about my care? And then it was, what are you going to do about this, Pete? You have a big role, and what are you going to do about this? And I felt complicit. I felt my whole career, I felt like if I make these organizations great, they do great things, right? This organization's a great organization with a great mission. So if I make it strong and great, I'm going to do great things for the patient. And what I found is very little of what I was doing had the customer in mind. And I should clarify, when I say customer, and we say customer at Baylor Scott & White, it's early on, people had a hard time with that in healthcare, as you might imagine. It's a customer, they're not customers, they're patients. And when we say customer, it's an elevated status. You are always a customer. You're sometimes a patient.
Mm-hmm.
And what that means is it does not, and in fact, it enhances the doctor-patient relationship. That doesn't go away, but it forces us to worry about you 24/7. And that's what I wanted for my dad. Why isn't this healthcare system worried about him 24/7? Why aren't they worried about his medication and the fact that he falls because he's got brain fog? Why? And focusing and saying, most of my career, what I did is we got hospitals and clinics. What are all the tactics? I'm going to just be really frank about it. What are all the tactics I'm going to do to fill them? And if I looked at the tactics, maybe none of them have the customer in mind.
I don't want to lose this because I think it's fascinating from a management standpoint. Yeah. So your background is on the financial side of it. So you see hospitals, healthcare systems from the number side of it, process that. All of a sudden, now you're in the operations side of it. You have to deal with all of these issues. You walk into an operating room, see that's a mess. You see it from your father's perspective. Talk about how then it changed your management approach in the sense of, were there other industries that you used as models? How did you start structuring, I've got to attack this? How in your mind, when you looked at this at that point in time, both from your father's standpoint, but also the system now having the responsibility, how did, from a management standpoint, a strategic standpoint in your own mind, how did you approach how you were going to attack it?
Yeah, it was actually, eventually, I would describe it as I crossed a bridge. And it was, and that bridge was the belief, and I could go through the business rationale, but really it's driven emotionally by purpose, is if I focus on the customer and their pain points and I solve them, the rest is going to happen. The rest will take care of itself. And what I mean by that is both financially and for the customer. So if I totally focus on you and what you need, you are going to have less pain and suffering. You are going to be healthier. And ultimately, and the research bears this out, it will be lower cost in long term. That's a good thing. And if I focus on you from a business perspective, you're going to be more loyal to me.
So what you brought, Pete, in the end, is you just frame the issue in a different way.
Totally different.
So as opposed to...
Right, but the tactics are different. That come out of it
once you frame it that way.
Right.
But the key is, it's almost not the answer, but it's the question.
Right.
If I ask the question of, how do I utilize these assets, I get one set of answers.
Yeah.
If I ask it from the standpoint of, how do I serve that customer a different way, then all of a sudden the answers aren't important. It's the question.
You absolutely. And sometimes I label it as supply driven versus demand driven. Supply driven is, I'm all about my assets and I'm all about making those things hum and filling them up. And demand driven is, I'm all about this person, this individual, my dad, your mom, your sister, your family member. I'm about that person. What does that person need? And objectively, what are their pain points? And even what are those things that we can create that they can't even imagine that are going to be really great for them?
See, Kyle, I think that's a big takeaway, because Einstein once said, it was a fascinating thing. He said, if I had an hour to solve a problem, I'd spend 55 minutes on the question, e.g. framing it, and 5 minutes coming up with the solution.
Yes.
So talk to me about the technology side of your business. Obviously, COVID was a massive disruptor for the world, but clearly for the healthcare industry as well, as medicine went virtual and was forced to go virtual really for the first time in history.
Yeah.
I think y'all released your 8th version of your app last year. And so technology is, I think, something that you guys value. Talk to me about how that has improved the patient relationship, ultimately the customer relationship, as you call it, inside your hospital system.
Well, I mean, and there's so much to say on this, but we're at such an exciting time on technology, and I'm certain you can't get through a conversation without talking about AI. But the way I would frame it, on technology is most health systems, we weren't any different. We had systems of record. And I would say our electronic health record is essentially a system of record down here, and it's transactional and it's gathering all this stuff. But we didn't have two other layers that were robust and that were really helping us be customer centric. The second layer on a system of record is a system of intelligence. So analytics, what do we learn from all this stuff? And now it's supercharged, right,
Sure.
with AI. And then a system of engagement, where, again, getting back to the customer, you don't care about the system of record. You don't care about the system of intelligence. You need what you want. And how are we interacting with you? So our app, early versions were that system of engagement and improved over and over and over again. What is it housing? At first, it was a digital front door. It's no longer that. It is, you receive care through it, you coordinate your care through it, you learn through it. All those things are part of it. And so we've spent a lot of time investing in all three layers, but particularly the middle and that top layer of engagement. And our belief is to transform healthcare, you need to be empowered as a customer and a patient. We have to move from a paternalistic system to one that is personalized to you, where you're in control.
And the younger generation, I would say, is so much more attuned to preventive medicine than previous generations.
Yeah.
I've got a Whoop on, the Oura Ring,
Yeah.
your Apple Watch. You've got these, call it systems that you're kind of working with on a day-to-day basis.
Yeah.
How do you kind of transform your view from like, hey, we're customer centric, to now we're going to reach a younger audience and we're actually going to be proactive on their behalf?
Yeah.
Towards preventive medicine.
Yeah. I mean, and this is where I believe the transformation in healthcare is going to occur. And I believe forward-thinking healthcare systems like Baylor are going to be at the cutting edge of this. You see disruptor companies. You've got,
Whoop.
that's one.
Yes.
Okay. And others, big tech and small tech, with point solutions on healthcare. They see it. They have the new tools. They're addressing needs in that regard. And then you have the legacy systems, which I call the walled gardens, that have all of the assets that when you need something, you're there. I don't see one or the other transforming healthcare individually. It's really going to have to be a partnership between the two to be able to be your daily health partner and unleashing that system of record data that is personalized to you. So if you have diabetes, or if you have a chronic disease, or if you have particular needs, or you just simply want to manage your life in a certain way, our app has to be, and our interaction, our full engagement with you has to be completely about you. And we have the ability to do it, but we just haven't applied it yet. I heard a stat the other day, so we talk about AI, and again, AI turbocharges this. AI today and the AI models are the worst. They're the worst they'll ever be, right? Today, which are pretty powerful. But 1/3 of the world's data is tied up in healthcare and is not even accessed by the current frontier or foundational models. So a health system like us, we're sitting on millions and millions of insights and transactions tied up and balkanized within our system, and technologically unleashing that in a way that we can give you a completely different experience and put you in a position where you can truly manage your health.
But I guess I want to challenge you and jump ahead a little bit of where I want. And Pete, that all makes sense.
Yeah.
But we still have to step back and say, in the United States today, we've got a healthcare system that's focused on paying for fixes. In other words, it is set up largely through Medicare, Medicaid, et cetera, where if you have a problem, I give you a drug, pharmaceutical, medicine, et cetera, or I cut you and fix you, e.g. surgeries and those sorts of things. How do you get to where you want to be when you still have this cloud over you that is a healthcare system that says, I'm not paying for prevention.
Yeah.
I'm paying if one of your doctors actually goes in and cuts me. So there's no incentive for that individual doctor to keep Kyle out of the hospital. They actually get a better deal if they cut him.
Yeah. Yeah. It's a great question. And I would say my thinking is evolving on it over time. But I think that there's a conviction I have, I call it the mega product. So the balkanization of healthcare is we're not going to do any individual transaction if we can't make money on it, right? So it basically says, okay, behavioral health to the side. Can't make money on that. Yep. Health system in the country, and I'll talk about that in a minute, but driven that out of the system. So if you have any behavioral health issue connected, like my mom, there's nothing for you.
So if you do that, your healthcare system, all you do is ortho and cardio.
Right, exactly.
Those are the money makers.
So the concept of us of filling these gaps and saying, listen, believe in the model, focus on the customer. If we do right by the customer, the financial sustainability will be there. And what we've seen is you get more loyalty. We used to believe at Baylor Scott & White that patients were loyal to us. Most systems do. They think our brand is great, they're loyal to us. They're not. They want access. And even though they really want to use you, if you give them a 6-month wait, they're going to go to the competition. And what we're saying is one of the keys to your question is access. So where do we have gaps in that totality of what you need? Let's fill those gaps. So for us, we did a big urgent care acquisition. We didn't have urgent care access.
That was in 23, right?
Right. One that we were just talking about is we said, listen, we don't have credibility for our patients and customers if we don't have behavioral health. We just don't. So we've done a partnership with a company called Geode Health. They have physical locations that have psychiatrists, psychologists. They have virtual care, in-person care. They have a model of behavioral health. They have 13 locations in DFW. We're forming a partnership with them. We're going to try to make it work. Will the first iteration be perfect? It's not going to be perfect. But I guess my point is I've zoomed out and said, what's the totality of what we're offering? And then you're gonna choose us. And those patients with choice will stay with us. And if that happens, we can make the total work. If we can create that engagement and that relationship that makes that work. Is it a gamble? Yeah, it's a bet. It's a gamble. But what I've seen is people working within the system, and I'll connect to burnout, by framing it, not just framing it, by believing it, people are energized. Like, this is why I got into healthcare. I got in healthcare for this. And as opposed to, well, we can't do that because insurance says you can't do that. We can't do that because it doesn't make money. So we're trying to actually resist that and embrace the total and say, let's go for it.
So how do you deal with that? You've got 57,000 employees that most all of them came up through a different view of the world.
Yeah.
Pre-Pete joining and leading Baylor. How do you kind of motivate and kind of bring 57,000 people along with you on this journey when you're kind of teaching them a healthcare system that's very different than they've ever dealt with?
Yeah. Well, I think one big aspect is to ask the question, how can you be connected to this overall purpose? So be really clear of what you're setting out to do. And what I share with our leadership and our employees is, a big part of leadership is clarity. So what are we setting out to do? But another big part is what I would call energy or purpose. So that's the what, but the why. What is the why inside you? Why do you come to work every day? And what we try to tap into and encourage people to tap into is answer that question. And for me, it's super clear. Like, my why has changed now. I'm not coming to work every day to create a great organization. I'm coming to work every day to solve my dad's list. And I'm not going to stop till I solve it. That question answered for others will be different. It'll be different. It'll be maybe similar, but that's the energy. Because if you can answer that question and connect it, there's nothing we can't do collectively if we answer that question. And what we're setting out to do, so very tangibly, one of our goals is to make all the interactions you have with us frictionless. Well, that applies to every single employee. And we're challenging our employees to say, listen, look at your world. We'll have some big initiatives that we're doing to make it frictionless, but every day there are hundreds of thousands of interactions. So how's the valet parking at the hospital? Does that really work? Have you really looked at it? It's kind of frustrating people. Can you fix that? So you start to get the flywheel going, and you get people energized on it. And that's what we're starting to
So it
see.
sounds like what you're saying is kind of from the employee standpoint, one, give them a sense of empowerment. They fix the problem.
Yeah.
It doesn't just get to Pete's desk. And then it sounds like the second piece is something that I think is a big part, so it resonates with me, is that in big change, you've got to drill it down to show why it's in the interest of each individual employee. And you're able to leverage off of a sense of purpose that you don't have in a lot of industries, to be frank.
Yeah, and I would add, another add to this is what we've said is, as we implement solutions that simplify the world for our customers, we are not going to implement a solution that makes your world more complex. And said another way, our intention is for you working here, we're going to simplify your environment. And that's been fabulous. I mean, the biggest one that recently happened, and other health systems have this, is the AI technology that's driving ambient listening. So ambient listening today is basically, I don't know if you're familiar with it, but it's a technology that if the old model is you sit down with your doctor and the doctor's typing into the computer, doesn't have eye contact with you, drives the provider nuts, and it drives you nuts. It's not a personal experience. Ambient listening today, basically they take out their cell phone and they say, are you okay with me doing ambient listening? It's just simply going to record this and I can have a conversation with you. They set it down. You have your appointment. I had this the other day with your doctor. It creates the clinic note. It creates the diagnosis, the this, the that, if they say, okay, we're going to give you a prescription for penicillin, blah, blah, blah. It creates the prescription, whatever. And you just had a conversation with your physician. Your physician just had an eye-to-eye conversation with you. Our doctors are thrilled by it. It simplifies their world and enhances their interaction. And for our patients,
Your CFO's got to love it because it's more productive too.
It's more efficient, much more productive.
I've seen physicians type. It's got to be much more productive.
Yeah.
So let's go a little bit deeper into the physicians. You've got over 7,000 of them. My mother's a physician. My brother's a physician. My mother would be the first to tell you that in her 40 years of practice, medicine.
But you never made it to medical
Totally.
school.
Well, I didn't get the math and science genes.
Oh, okay.
That's a good thing. They don't want me in medical school or anywhere near a doctor-patient relationship. But in 40 years of practicing, my mom would very much tell you that the rock and roll 80s of being a physician in the 80s and the 90s were high times.
Yeah.
And it's, by and large, has vastly changed.
Yeah.
So how do you partner with and ultimately incentivize the physicians to be at your hospitals?
Yeah.
What's that relationship like?
Well, I think it takes a lot of different forms. I think the most fundamental form, in my experience, physicians got into medicine because they want to help people. And if we are committed, again, to the customer and the patient and helping them, I've seen a lot of engagement for our physicians. Like, finally, you're solving some of the most frustrating aspects of medicine. The example I'd have is we've deployed a completely touchless check-in process. I call it, we're going to have a bonfire of clipboards. It's just like, why are we doing this? And it's just frustrating for physicians. By the time the patient gets in the exam room, they're already frustrated. And so it's on us to help them do that. So can we bring the joy back into practicing medicine? I think that's at the core of it. It's not an incentive issue. It's how do we bring that back? Now, incentive-wise, there are all other ways where they are sort of co-partners in the delivery of care. And we have that in Baylor, Scott & White in some fashions. But I think at the core of it's bringing the joy back to medicine.
I think that's so interesting because most physicians are not necessarily business people.
Right.
They're physicians because they want to help people.
Yeah.
They want to be the front line of defense or offense for their patients.
Yeah.
And I think your point there is so right, is how do we take a process that can be marred by friction and move it towards efficiency to ultimately get the patient in the room and get them the care that they need. So it's a great point there.
But that, again, forces us to jump from Baylor to kind of national to friends.
Yeah.
If I think of the doctors I know, They got into it in a lot of cases because their parents or grandparents were physicians. I talk to doctors today, and they're telling their kids, stay out of it. It's a horrible business, horrible situation now. All I deal with insurance companies, et cetera, so I'm trying to get out of it. We also have a challenge in the United States in the sense that the number of effective physicians coming out of medical school has been reduced. Years ago, you'd have a male come out, so you'd get 40 years worth of man-years worth of medical service. On the female side, it's much more 50-50 now in terms of medical schools. A lot of them leave at various points for families. A lot of the individuals who go to medical school now go into research. They go into pharmaceuticals. They go into hospital management. So each individual slot in a medical school, we don't get quite as much out of it. So we've got this real challenge of getting physicians, one, motivating people to get into the business, as well as generating the numbers. And a lot of my understanding, the reason that we don't increase the number of medical schools or medical slots in the medical schools coming out is the government years ago said, well, we don't want more doctors because they'll order more tests. If they order more tests, Medicare's got to pay more. So that's the bad situation, kind of going back to the old thinking. How do we as a nation kind of, again, reinfuse what you've been talking about of this desire to really get in and feel that you're making a difference on an individual basis as a physician?
Yeah. I really believe we're at an inflection point on medical education and what is the role of a physician. And right now, physicians are doing work that is really beneath their capability. It's bogging them down. And how can we utilize technology to free them? I mean, these are the smartest people, at least in my school. The people who went to medical who are smarter than me. I mean, these are brilliant individuals plus committed. And how do we free them up to do the things that they're uniquely capable of doing? And there are so many opportunities. The other thing that's happening, example, I guess I would say, is the power of AI around diagnosis is stunning. I mean, it is stunning, and the applications are good for the doctor and they're good for the patient. I mean, the example would be the application of AI in imaging. So if you're a radiologist, you're working your queue, you're in the hospital or you're somewhere else remotely, you're working your image scan, you're reading radiology reports. Well, in a hospital, you've got incomings to the emergency department to get a CAT scan. There might be a critical finding. You might be on the verge of a stroke or whatever it might be. Well, that image goes in the queue. And eventually the radiologist reads it and gets to it, right? New technology, AI reads every scan that comes into the flow. It immediately catches yours, it pushes it and pops it right to the radiologist and says, I have a potential critical finding, please read now. Boom, within 1 minute. There's going to be application of technology in our environment. It'll be malpractice not to apply it. It's just a small example.
I was visiting with a physician, and they made the comment to me that 50% of the textbooks in medical school today are outdated.
Yeah. I mean, the testing, I think it's a little bit crazy today. We're testing how smart you are, how you could memorize parts of the body. I mean, the whole focus has got to evolve, and in the new environment, knowledge is going to become a commodity. But insight and wisdom and decision-making and judgment and empathy are going to be premium skills.
I want to jump to the bigger macro issues in healthcare in the nation. But before we do, give a context. You've outlined a strategy and a tactical approach at Baylor that sounds very different than I think most of what I've heard. But give us a context. Are there other organizations across the nation that are doing this, or is Baylor unique? Is Baylor kind of the pioneer in this? And I'm putting you on the spot a little bit. I appreciate that. But give us a sense of where this falls into kind of other major healthcare systems, not just in Texas, but across the nation.
Yeah, I would say, all due respect to other legacy health systems, many of them are using the same words, but it's an initiative. It's like we're going to become more customer-centric or patient-centric, and we're going to apply technology. It's how do we incrementally take this legacy system and make it more this way? The difference for us, it's part of our DNA.
Doesn't work. You've said that a number of times.
And transformation. You have to buy, which means, and this isn't personal to me, it just means the CEO, it is what the CEO does. It is not one of 12 things. This is what, and if there is a barrier to that vision, active engagement by me and my senior team of roughly 12 EVPs all understand that, and they're driving to that. So it's a question of focus, conviction, belief around it, where it's central to what you do. It's a difference between a transformation and incrementally getting better, because you get these organizations 100 years old. They're not, it's as if you're an auto company who says, I'm going to dabble in electric cars. At some point, you got to go all the way and say, we believe in it. Now, do I see other companies doing it? Yeah, there are other companies, disruptor companies, but again, they have the problem. They don't have a health system. So you got to put the two together.
Within the context of health system, sounds like you are a pioneer.
So stepping back, just like super global, if I take a look at our healthcare system and I take a look at a lot of the rest of the world, specifically Europe, the UK has a single payer system. Germany has a universal healthcare system. We have not gone that route. The Affordable Care Act was a step in a lot of directions, varying amounts that have stayed in place, varying amounts that have not. Where do you see the U.S. healthcare system as it relates to the rest of the world? Where do you see our care? And the ultimate thing is, where do you see, how do we prevent negative outcomes as it pertains to the rest of the world?
Well, and to jump in on that, we spend, depending on the nation, twice as much on a per capita basis in our healthcare system today, which is a large criticism. We're spending, as percentage of the economy, anywhere from 16 to 20%. I see different numbers, but at least 16 to 20. Scandinavian numbers, countries you mentioned, probably single digit, maybe middle single digits. Why the difference? Are we getting our money's worth, to Kyle's point?
Yeah. It's, what can you say about this? There's a lot to say. I do think it's a question of choices. What are the pros and cons?
Why do you think that is? Let's just.
Why do you think the disparity?
Analytical, just twice as much. Is it?
I'll first answer it by anecdote. The most complex, costly cases that I've been exposed to through my 40 years of career have been cases of people who had bad access to care, and their situation was either misdiagnosed, misunderstood, got to it late in its progression. So, obesity would be a great example. Too late. And forms of cancer or neurodegenerative diseases, our system doesn't respond. Sort of our culture. Our culture doesn't respond until it's a crisis.
So back to fix versus prevention?
Right. And these other ones, because they have single payer, everyone's got reliable insurance for the long haul. Those issues are at least adequately dealt with. And we've got segments of our population where, the problems are pervasive because of issues of access, and you can see those disparities. And for example, your mother's in OBGYN, maternal mortality. For people of color, it's 3 to 4 times. Now, why is that? Well, it's access. They live in communities where they don't have follow-up care after delivery and that. So those issues are pervasive in our healthcare system. But the question becomes, how can we work from our strengths rather than taking a model, laying it on top? And from my perspective, let's work from our strengths. Number one, I don't think a single payer culturally will work in the United States. We want choice. It's just part of our DNA. But the good news about that is it fosters innovation. So the bad news of single payer is you don't get innovation. And in a period with rapid change in technology is how can we use the strengths of our country and our society to foster innovation in such a way that organizations that make it work and get the results that you're talking about are rewarded for that? And how can we foster the injection of disruption and innovation to get to that other end of it? I think the one that is the most corrosive, I would say, within the U.S. healthcare system is the uninsured. We just, and this is not a political statement, because if someone said, what is the single thing, if you only had one thing to help people with their health, the answer is give them health insurance coverage, at least. Because if I don't have health insurance coverage, I didn't have health insurance coverage, I'm not going to the doctor because it's going to bankrupt me. I don't trust the system to take care of me. And so that leads to bad health outcomes.
But is that a first dollar out or is that a catastrophic?
I think it's a blend. I think it's giving you enough based upon your income level, enough incentive to be thoughtful about the utilization of care, but definitely supporting you catastrophically. I mean, definitely where you don't not seek care because you're afraid that it's going to bankrupt you. So is there an easy solution to that? No. But I think in my view, should guide us when we have these sort of forks in the road. Do we go here or we go here? Is to at least, because from an employer standpoint, employers should be really interested in the uninsured. Because you know where that cost goes? It goes directly there. And that our healthcare system is very bifurcated that way. I mean, employers pay a much larger premium on cost because the government and the uninsured zero, government underpays versus cost 25%.
Is that part of the problem in the sense that the consumer, we'll use the word for a moment, is largely divorced from the cost? So if you and I go buy a TV,
sure,
we pay for a TV.
Right.
We see it.
If we go buy healthcare, I don't see it.
Right.
And I might pay $10 as a copay or something like that, but I don't see it in either Medicare or private insurance, the amount of the drugs, the cost of the doctor, et cetera, all of those sorts of things. Is part of our problem that we don't have really the consumer having kind of skin in the game, so to speak?
Well, there's increasingly some. So step one is whatever skin you have in the game, it should be transparent to you. Yeah. So when you go to the doctor, how much, what you're interested in, how it's going to cost you. Right. I mean, some of us worry about the rest of it, but most of it, how it's going to. So at a minimum, let's make it transparent to you. And that's one of our initiatives in terms of, one of the biggest pain points for our patients, customers is the financial experience. And transparency is one of them. Like, I don't know what it's going to cost me. Like and it keeps people from, for example, getting a preventive colonoscopy because they just don't even know what it costs. Is it going to cost me $6,000 or $60,000? So at least create transparency there. And then the other question is, how do you direct care to the highest quality, most efficient providers? And that one's a little bit more complex. Given the complexity of healthcare, but that's where insurers and providers have to really collaborate in a way that Baylor Scott & White is rewarded for being efficient with its pricing and efficient with the utilization of care.
Yeah, I'll relate a situation when I was involved on the public side and we did some work in the healthcare system. We did a survey and it was up and down Central Expressway, which is large freeway in Dallas, Texas, kind of downtown to a lot of commercial as well as residential neighborhoods. And we looked at the cost of an MRI and made sure that it was exactly the same MRI. And in a space of 4 miles, the cost of that same MRI ranged from, I think it was slightly over $500 to just below $2,500.
Right.
It was amazing that kind of said, if you were in any other industry, if you were pricing at $2,500, how would you ever survive?
Right.
Because when I go to get lunch today, I'm going to see every single price of a sandwich, salad, soup, whatever it may be. But healthcare, we don't have that.
Right. No, you're identifying some of the problems of the current healthcare.
So how do we get more transparency? More transparency in drug prices. We'll get to that in a moment. But transparency in terms of all of the costs of a healthcare system.
Yeah, I think from my standpoint, yes, that's an issue. I think the question becomes, in total, what is the cost to you? In total, like if you buy an automobile, the cost of the accessory that you're buying versus it's what's the total package, and what healthcare systems are delivering on that total cost. And again, I think that's a collaboration between payers and providers so that there's a clear understanding of that. And so it's a complex issue. I mean, the price schedule, and I'm not apologizing for healthcare, but since Medicare and Medicaid in the mid-'60s, I think a typical hospital's price schedule, there's 15,000 items on it. I mean, it's a broken system from a pricing standpoint, because we've said we're going to pay for every individual transaction that's done on you. Yeah. And the payment system will have to evolve over time to get rid of that.
Again, a little bit back to that fix versus prevention.
Right.
So
go ahead.
I want to take us to one area and really talk about Baylor and the future of your healthcare system. What's next? You talked about this partnership on the behavioral health side. What other things are on the horizon? Any fun initiatives that are being enacted today outside of that?
Yeah, I think we're moving on to what we call version 2 of our transformation. And I touched on it a little bit. So version 1 was really have an engaging app. And other thing on version 1 was have a navigation system. So it's a massive pain point, navigating healthcare, particularly if you have multiple conditions. Interestingly, just as an aside on that, we launched a navigation program, which is a mixture of AI and human interaction online with you from your symptoms to an appointment, all in one. And we navigate them to the proper node in the system where there's access. Okay. Sounds like a simple thing the rest of your life, but in healthcare, it's a big thing. We ask them, where would have you gone if you didn't use this navigation system? More than 60% of them would have gone to a different node, and it would have been a higher cost node. Yeah. So basically the analogy is we're running an airline where you want to go from Dallas to Chicago, and more than half the time we send you to Denver. And then you got to go from Denver to Chicago, and we charge you for both. It is a totally broken system. We have this complex system that an individual is trying to navigate. So part for us is we're going to take the digital platform and convert it from a digital front door to a daily health partner, which has a whole lot of features in it. Number 2, we're going to take this nascent navigation system and really power it by AI so it becomes super intelligent. So the criteria for where you should go becomes very sophisticated. There are criteria out there today, by the way. The algorithm runs like this. And these are formal criteria that have been out for 30 years. You call up, and you present with symptoms. There are 2 nodes of choice, doctor, office, or ED. If there's any question, go to the emergency department. That's the sophistication of the algorithm. We're saying, no. There are so many choices. There's urgent care, there's virtual, there's asynchronous care, there's home care, there's self-care, there's, you name it. There's medication management. So that aspect becomes, that's version 2.0. Is very, and then the most important piece, which has hundreds of tactics underneath it, is to move from a supply-driven health system that's episodic to one that's demand-driven and continuous. Now in those first 2 pieces, I know what demand is. I know what people need and want, but now I have to critically look at the supply base of assets and totally reconfigure them. And that's what's led us to the behavioral health. There's a total gap in our system. We got to fill that gap. It's going to lead us to investments in other areas. It's going to lead us to turn down certain things that don't relate to what our customers need. That's the hardest piece. But if we do all those 3 things and we make your experience and all the micro things that occur frictionless, we have transformed medical care. That is a distinctly different, that differentiates us and makes us indispensable to you. That you don't want to go anywhere else because we've done that. That's in a nutshell. That's the future of Baylor Scott & White in a nutshell.
You've laid out this vision for Baylor. It is a very different vision. What we're seeing in Washington is a very different approach to healthcare too. This administration is taking a very different view, being criticized in a lot of areas. Others folks are supporting it. As the CEO of Baylor, with a different vision, trying to accomplish a very different thing, how do you look at those changes in Washington, the administration? How will they affect you? And what would you want out of the administration to kind of support where you see healthcare system going and where you're leading Baylor?
Yeah. I think one approach that I've taken for a number of years when it comes to federal or state policy on healthcare is let's find the pearls in there. So there's going to be a lot of things that aren't good, and particularly they're not good because they go right at our funding in a very thin margin business. And I understand why. We're going to have massive budget deficits for as far as the eye can see. It's going to manifest itself in terms of reductions in what we get paid from the government. There's no question. It's not Democrat or Republican. It's a reality. Yep. So there's that. So there's a lot of that we don't like, but it's a reality. But some of the stuff we do like and that we want to expand upon is promotion of interoperability of data. So this segmenting of data among companies, EHR providers, so on and so forth. And in that balkanization, the only way we can transform healthcare is to open that up. And because by opening that, you've been in the tech sector, until you have interoperability, you can't innovate because you're constricted. I mean, I can tell you, we've explored certain solutions and they've said, well, if that big provider is still controlling the environment, we're not going to go there because they're just going to squash us. So creating a much more open playing field around technology and innovation, I see as positive, and I see that coming out of the administration. That's really good. I do think also breaking down state barriers to the practice of medicine becomes important, because how can you, particularly because there are a lot of hybrid delivery approaches that involve, why can't you be treated for, just take Parkinson's. Let's say a local doctor can see you and get your symptoms, and why can't you be treated by the world's expert in Parkinson's? Well, because he or she resides in Colorado and it doesn't reside in Texas. Well, what other thing that we do has a boundary like that? So liberalizing the boundaries, the practice of medicine.
Is that a kind of logistical question?
It's a regulatory
question or a standard of care region to region?
Well, standard of care, you obviously have to create a safe and high quality standard of care, no question. But once you have
nationally, as opposed to what it is today, regionally.
Yeah. But you could open it up and break down the barriers. So then, because some of the products we're developing, they are not geographically constrained. The navigation system isn't geographically constrained. One of our products that is a postpartum product that basically is a 24/7 assist to a new mother and everything that they need. And then eventually, if they need something, we can deliver it to their home. That's not constrained by geography. I could have relationships nationally and deliver that product. So those things are good. Simply going at, we're going to solve healthcare by reducing, but it's what government does. I mean, it's just like, we're going to solve healthcare costs by price control. It's price control. Right, yeah. Well, we know it's not going to work. It's not going to work. It just pushes that somewhere else and creates a system that could be very low cost, but is not going to be good for you maintaining your health.
Well, that's one of the things I think all of us want to hold on to.
Yeah.
If you look across the world today, the United States is clearly viewed as the leader in medical innovation, be it drugs, be it procedures, or be it devices. Yep. How do we maintain that with all of this price pressure coming on? And again, one of the things we see all the time is the drug prices in Canada are a fraction of what they are in the United States.
Yeah.
How does the American consumer win? But at the same time, we continue to be the leader in providing the new cancer treatments that are going to cure people at Baylor, all of the new innovations in devices. I talked to my physical trainer who's having his hip replaced today.
Right.
Those sorts of things that 20 years ago you would have never thought were possible.
Yeah. Contrary to what some people might expect from someone in my position, I am a really big believer in pharma and biotech. I mean, I think that those discoveries are going to change our health span. I mean, and particularly, again, the application of AI in clinical trials. I mean, I just think there is a very optimistic future there, and we should not constrain that too far, because that's where many of the solutions are. And I think where I see problems is where you get somewhat monopolistic behavior inside of that. And so alternatives that have evolved, which have been so for example, we have a number of drugs that there's one manufacturer for it. Might not be a cutting edge drug, but it's very common. Well, health systems have formed a consortium to actually manufacture that, so that we're not constrained by one manufacturer who then says we're going to triple the price of IV fluids.
It's not a patent issue or anything. It's just
no, it's not a patent issue at that point. So being able to have a competitive playing field that keeps pricing, because competition keeps pricing down. That you don't have to have price controls, you have competition. And then having reasonable policy around patent protection so that it is at least providing the incentives to the people who discover these things to get an adequate return. That's the balance we have to reach. But there's some things happening on the biotech and pharma that are going to save lives, and very specialty drugs. The growth of specialty drugs can be off the charts in the next 10 years.
The longevity, I know Kyle and I have talked about the longevity piece, and kind of hidden in that couple of paragraphs there, you used a word that is a different word than a lot of people use. You used health span.
Yeah.
Most people will use the word lifespan, e.g. how long you live.
Yeah.
To me, lifespan is how long you live. Health span is how long you live healthy.
Right.
Talk about the difference of those and how you see that within the Baylor system and what you're trying to do to push that health span to come closer to lifespan.
Yeah. I mean, and I'll come back to what I was saying earlier. The most common example of that is chronic disease. Chronic disease, I can suffer from arthritis, or I can suffer from diabetes for 100 years. I could have great lifespan, but it's horrible health span. I'm suffering from that. Yeah. Our focus is it's health span. And what's underestimated, and again, I saw this in my dad's care, what's underestimated is you've got two health systems or two providers that say, listen, I cured that condition. Someone maybe had chronic pain. Well, I cured your chronic pain. And this one said, I cured your chronic pain. So, well, equal quality, right? No. In this one, you waited 8 months before your chronic pain was cured. This one, you waited 2 weeks. That's a massive difference and a huge difference in health span. But that expanded to chronic disease in general, which our health system is not set up to deal with chronic disease. We have got to fix that. It's episodic, it's acute condition. That's health span. I'd rather live to 80 with a good health span than 100 without dealing. I mean, there's just no question. And the focus should be on, in my view, should be on health span.
So I want to tie a couple of things together, and this may get a tad controversial, so apologies in advance. You talk about the pharma and the biomedical innovation, and we talked about AI, we've talked about data. For a younger generation, there's also a massive distrust of the healthcare system.
Yeah.
There's a move towards alternative medicine and people that are not highly trained, not certified, not a lot of things that are providing input and supposed wisdom. Supplements.
Yeah.
But TikTok videos, Instagram videos.
Right.
It's rampant. So as you look at a healthcare system, how do you regain the trust of ultimately your next generation of user in a lot of ways? Because the younger generation is likely healthier, but over time, the body breaks down and, that health span becomes shorter. How do you gain their trust, and how do you inform them of what's really right, appropriate medicine?
Yeah, I mean, it's a great question. It pervades every aspect of our society. So how do large institutions that for hundreds of years have had the role and the responsibility and the mission to do a certain thing, what we do, how do we offset in the clear misinformation that's out in the environment, particularly through social media? Vaccines would be a classic example,
Totally.
right? This latest one, the American Academy of Pediatrics came out and said, young children between 6 months and 2 years should have a COVID vaccine, and the federal government said you shouldn't. So what do we say about that? And we know that the vaccine would have saved their lives. So I mean,
right.
But I think it gets down to, like anything, and I would say even outside the healthcare sphere, it's why you choose a brand. You trust it. You trust that it's going to meet your needs. And healthcare systems today, people don't trust them because I'm not meeting your full needs. So by meeting your needs daily, and I'm now your partner in health, you're going to trust me. I think you're going to trust me. And you're going to say, TikTok video doesn't have my data. Right. TikTok video isn't offering up to me a personalized experience. That's me. This is me. One by one. That's what I'm going to go to. This is for me. This is for me. So that's where I believe that. And that's on us. That's on us. It's not on the consumer. It's not on the patient. It's on us to get there.
So how do you bring all of this new innovation research into the Baylor system? Clearly new drugs, but procedures, all those sorts of things that are really making difference kind of on the frontier there.
Yeah.
How do you, from a research standpoint, given the cost, try to bring those in at the right time?
Yeah. Wow. That's a really good question. I mean, we have, for clinical applications, direct clinical applications, we have a very large research institute. And it's unique in that, like if you went to UT Southwestern, they have a huge research arm, fabulous NIH research, really first in human research. That's a fundamental role of an academic center. Our role is when devices, pharmaceuticals, practices are approved and now they're being done, ours is to do the clinical research. And we have, 12 million encounters a year. We've got 3.5 million connected patients. We have the proving ground to be able to assess, are those things working? So that's one aspect of research. That's taking the classic device, pharmaceuticals and like. The rest of the innovation around bringing technology and innovation, and I would say customer insights into healthcare, we invest heavily into that because this first piece is a continuation of a strength in the past. The second piece is where some of the big innovation is. So truly understanding, both observing and listening with our customers and patients of what their needs are. We don't fully understand that. We don't understand our customer needs as well as Procter & Gamble understands what consumer practices are. And we need to get to that level.
Does the nation understand that? I'm thinking of the regulatory process for new pharmaceutical drugs, et cetera. Are we getting the innovative drugs in your hands quick enough?
When I mentioned specialty drugs, so there's a massive explosion. There's sort of your common medications, and then there's these really high cost specialty drugs that solve a particular condition, like sickle cell. If you have sickle cell, this gets at it. That piece needs to be expanded. And we're positioning ourselves with a collaboration with other health systems to build out specialty pharmacy such that our health systems are getting access to everything that's coming out. So if you come to Baylor Scott & White, you have full access to that. And I think opening those channels, it becomes crucially important.
Fascinating.
Go for it. You're clearly making a big difference. And I think what resonated with me is I hear a lot of healthcare institutions they've got the talking points down right, but they're not translating it in. Mm-hmm. And when you talk about you can't do these things incrementally, you have to do it transformational. You have to change the organization and at times flip it upside down.
Yeah.
That really resonated with me. If we talk to you 5 years from now and say, Pete, it's 2030. Tell me how much Baylor's changed since we got together in 2025. What would that conversation sound like?
Well, I think the question for me is, how has it changed and how has it not changed too?
Okay.
What are
fair.
certain things that are enduring
Yeah, we didn't keep the same.
in Baylor Scott and White? I think how it's changed is honestly, no matter where I am, I'm interacting with Baylor Scott and White on managing my health and my well-being, and Baylor Scott and White's delivering, and it's personalized to me. That's what's changed, and that doesn't exist today. We've got a lot of wood to chop, but we're it's
coming.
It's 7 a.m. and we've had our cup of coffee and we're going to do it. I think what's enduring is the mission of Baylor Scott and White. Founded as a Christian ministry of healing, we promote the well-being of individuals, families, and communities. And what does that mean? It really means the heart and soul of Baylor Scott and White. It's compassion, it's love for anyone in our communities is continued to be expressed, and is that we go the extra mile. The example I give a lot of times is Baylor Scott and White has the opportunity to continue its legacy through the full expression of the parable of the Good Samaritan. That, if I reread that a lot of times because I think it serves as a perfect example for our health system. And in the parable, there's so many elements to it if you reread it all the time. The person helping, when I was a kid, I thought, oh, well, there was a Samaritan who was hurt on the side of the road and a Jewish person came over and helped him. No. There was a Jewish person who was helped, and then the Samaritan came and helped. I mean, even that one, okay? But the other is, the Samaritan didn't just patch the guy up and send him on his way. He put him on his horse. He took him to an inn. He told the innkeeper, here's some money. So if he needs anything,
All right.
give it to him. And then he said, so that when I come back, there's reference, he's going to come back and check on him. It is everything that we've gone the extra mile, and that we're not just doing that first one and saying it's not our job to do the other stuff. It's our job to do the other stuff. We've got to ask the questions, how do we do the other stuff? And how do we give every individual we encounter, no matter who they are, we express that love to them and that compassion to them? That's going to be enduring. And that's what drives us. That's what we're tapping into here. And that's who we are.
You mentioned the origin of Baylor was a very strong faith-based Christian organization.
Right.
How important is that to the Baylor of 2025?
Yeah, it has, I would say it has two importance. Number one is what I just said. It the full expression of Christian values. And you don't need to be Christian to endorse that. It's that you're endorsing the human condition and expressing love and compassion to everyone. And our 57,000 employees can get their heads around that. So that's crucially important in the environment. The second piece is really important to us, and that is that in the workplace, we encourage the expression of your faith and your spirituality, no matter what that is. So it's okay to talk about your spirituality in the workplace. And our mission and ministry division does a fabulous job really embracing people of all faiths and being able to, it's part of their life. Why create this segmentation? And that's an important cultural element for us as well.
I've been incredibly impressed today. This has been really fun. I think the idea of you checking off the items that your father wrote down and transforming that into how you run a 57,000 person organization is kudos to what you believe, your conviction, and ultimately your discernment as it pertains to the future of medicine. So really impressed by that.
I think I've, over the years, managed some pretty tough organizations. Comparing those to what you're dealing with in the healthcare industry with the challenges you've got and the size and the complexity of 1,300 access points, I think you're doing the triple reverse off the 10 meter.
Yeah.
And I'm rooting for you.
Hopefully there's water in that pool.
Yeah,
We hope.
exactly.
We hope.
But it is. This is something, and it is. We think of all industries, and we want to tell our people that what we're doing is important, is critical, and I think that is the case in any part of our economy. But when you look at healthcare and you look at what's at stake when somebody walks in to one of those 1,300 access points at Baylor, you think of the size the industry represents of our economy. And to be frank with you, the word you used on the front end, some of the messes we need to fix. I'm very appreciative of what you're doing as a consumer or patient of Baylor. I'm seeing the changes that you're making. So that is at least gratifying from my perspective, and I know it's got to even be even more so. So we appreciate everything you're doing. And again, not just the dedication, but the commitment to actually make the change, take the talking points and actually turn them into action.
Yep.
Pete, thanks for being with us.
All right.
Pete,
Great.
thank you.
Really enjoyed it. Thank you.